Now we're going to go over the digestive system. Some terms that you need to write in your book are gastro, which means stomach, lapar, which means abdominal wall. The vermilion is the upper and lower lip, the red portion. 59 modifier is used in this section. Two separate procedures or incisions indicate the use of a 59 modifier when appropriate. You need to write down that the large intestine includes the cecum, ascending, transverse, and descending colon, sigmoid colon, rectum, and anus. The small intestine includes the duodenum, jejunum, and ileum. Now let's look at the anatomy of the digestive system. You have your salivary gland at the back of your mouth, your esophagus, which is your throat, your liver, stomach, pancreas, your small intestine, your large intestine, your gallbladder, and your rectum. These are the sections of the digestive system. As you can see, it goes by the anatomy. It goes from the lips all the way to the abdomen, perineum, and omentum. Let's talk about a colonoscopy. These are very common procedures, and you're sure to see one on the exam. A colonoscopy is an exam of the entire colon from the rectum to the cecum. It's important that you note that the colonoscope must go past the splenic flexure to be considered a colonoscopy. It is considered a colonoscopy when the entire colon is examined. Look at this picture. You can see the colonoscope goes all the way from the rectum to the cecum. So the definition of a complete colonoscopy is when the colonoscope goes all the way to the cecum, which is this area right here. Now let's talk about coding for a colonoscopy because it's different from Medicare versus other payers. Most people, or a lot of people, go in to have a screening colonoscopy when they get a certain age. There are different types of screening colonoscopies. There's people that are at high risk for colon cancer and people that are at low or average risk. So Medicare wants you to use a HCPCS code for this. So if you want to look at these in your HCPCS book, go ahead. It's GO121 and GO105. And it says GO121 is for a low risk or average risk. Low risk or average risk is someone who has not had a family history of a colon disease or cancer, as well as a personal history. They haven't had polyps removed in the past. They haven't had any type of personal history. A high risk are patients that have had that history. So those are used for screening colonoscopies. If a patient, we're going to talk about what happens if the patient comes in for a screening and they find something during the procedure and have to do a surgical procedure during the colonoscopy. We're going to talk about what you do then, but this is for the people that come in and no procedure is done. They're just looking at the colon. Then you will use these G codes for Medicare. If it's other payers, you're going to use the diagnostic colonoscopy code 45378. So that's important. I would write that on the page and I'll show you my book here in a second. When a patient comes in for a screening, there's a diagnosis code that needs to be used first. That is Z12.11, encounter for malignant neoplasm of colon. If any diagnosis comes out of the screening, it shall go second. The personal history codes should also go second, or family history codes of colon cancer, colon polyps, or disease of the digestive system. You can make a note of this on this page in your CPT book. Finally, for screening colonoscopies, there are specific modifiers if a screening colonoscopy turns into a surgical colonoscopy. For Medicare, if the colorectal cancer screening is converted to a diagnostic procedure, such as a polypectomy, biopsy, etc., you will use a PT modifier on all colonoscopy code, and you will not use the G screening code. For other payers other than Medicare, you will use the 33 modifier. Modifier PT and 33 are attached to a CPT code to inform the insurance company that the colonoscopy started as a screening but ended diagnostic therapeutic. Modifier PT is used for Medicare claims and Modifier 33 is used for commercial payer. Now we're going to talk about a common procedure done with a colonoscopy, and that's a polyp removal. A polyp is a benign lesion of the colon. Polyps can be removed by snare technique, hot biopsy, or ablation. So you should code based on the technique used. Don't get a hot biopsy 45384 confused with a regular biopsy or sample of tissue. That's 45380. On 45380, it doesn't matter how many times they biopsy the colon, it is only coded once. Now let's look at my book. This is the table of contents for the digestive system. The colonoscopies are under colon, rectum, endoscopy. The colonoscopy codes start with 45378, and I have written next to this diagnostic screening for commercial payers. At the top, I have screening modifier if diagnostic turns into procedure. PT for Medicare, 33 for other. So this 45379 is a colonoscopy with a removal of foreign bodies. 45380 is with biopsy, single or multiple, so you cannot code it more than once. 45381 is with directed submucosal injections. 45381 could talk about tattooing as well. 45382 is for control of bleeding. 45388 is an ablation of tumors or polyps or other lesions. And because there is the S next to it, you cannot code it twice. Only be coded once per polyp. If there's different techniques done on different polyps, you can code those. 45384 is for a removal of lesion by hot biopsy. 45385 is by snare technique. 45386 is with transendoscopic balloon dilation. Now it's your turn to try with scenario 1. This is a Medicare patient. A 70-year-old patient presents for an outpatient surgery area for a screening colonoscopy. The patient's previous colonoscopy was at 59 years old and was positive for 1 colon polyp. The patient has no history of colorectal cancer and no family history of polyps or colorectal cancer. The colonoscopy is performed in its entirety and was normal. Look for your code now. You should get Z12.11 for encounter for screening of malignant neoplasm of colon, then the personal history of colon polyps because it did mention that he had one removed, and then G0105 for colorectal screening colonoscopy on individual at high risk. The reason this would be coded as a high risk is because he did have a polyp removed. Number 2, this is a non-Medicare patient. A 55-year-old patient presents to the outpatient surgery area for a screening colonoscopy. She has not had a history of polyps or colorectal cancer and has no family history of either. During her screening colonoscopy, a polyp was found. The surgeon removes the polyp with a snare technique. How should this be coded? Pause this video and get your answer. You should have got Z12.11 because it started out as a screening colonoscopy. Your second code should be polyp of the colon, K63.5 for your ICD-10 codes. For your CPT code, you should have gotten 45385 for removal of polyp or other lesion by the snare technique. The 33 modifier is used because it started as a screening and turned into a procedure, and this is not a Medicare patient. So the PT would not be used. Instead, it is the 33 modifier. Now let's talk about a sigmoidoscopy. We talked about the colonoscopy, but a sigmoidoscopy is when the colonoscope only goes to the sigmoid colon. And it has the same procedures as a colonoscopy, but it's just not going as far into the colon as you can see. The green portion is the sigmoidoscopy, and if it goes past that, then it is considered a colonoscopy. So let's look at the sigmoid section of the CPT book. On the coding tip in my book, it says a sigmoidoscopy is the examination of the entire rectum, sigmoid colon, and may include the examination of a portion of the descending colon. 45330 is the diagnostic sigmoidoscopy, and then you have the same procedures that we talked about for the colonoscopy, the biopsy, the hot biopsy, polyp removal, the snare, the foreign body removal. So we won't go over all of those again, but I do want to point out the diagram at the top of the page. It says, decision to undergo colonoscopy. Was it diagnostic or therapeutic? So in this case we just did for the colonoscopy, it was therapeutic. It's saying, does it reach the splenic flexure, beyond the splenic flexure, not to the cecum or to the cecum? So like I said, when the colonoscope goes all the way to the cecum, then it is considered a complete colonoscopy. However, if it at least gets past the splenic flexure, it is considered a colonoscopy. If it does not get past the splenic flexure, it is considered a sigmoidoscopy. So that's important to know, and this tree will help remind you of that. There's one more thing for the colonoscopy and sigmoidoscopy I want to point out in the guidelines. Colonoscopy is the examination of the entire colon from the rectum to the cecum and may include examination of the terminal ileum and small intestine proximal to the anastomosis. When performing a diagnostic screening or screening endoscopic procedure on a patient who is scheduled and prepared for a total colonoscopy, if the physician is unable to advance the colonoscope to the cecum or small intestine due to unforeseen circumstances, 45388 or 45378 and 44388 with the modifier 53 for discontinued procedures should be performed. That happens a lot where they can't go complete the colonoscopy due to unforeseen circumstances, but their intention was to do a colonoscopy. When that happens, the 53 discontinued procedures should be appended to the code. Also, it did mention a colonoscopy through a stoma. A stoma is an artificial opening, and if they are not going in through the rectum, but they are going in through an opening they created, and then using the colonoscopy, that is considered a colonoscopy through a stoma and should not be coded with the regular colonoscopy codes. You should go to code 45388 and look in that code range. Now let's go back to the beginning of the section for the digestive system and look at the lips and vestibule of mouth section. You should know that vermilion is the upper and lower lip, the part where lipstick goes on. Vermilionectomy is 40500, and it is the excision of the red margin of the upper and lower lips. This is different from a chiloplasty, which is a plastic surgery of the lips. Look carefully at the codes for repair of cleft lip. Some report unilateral procedures and others are used for bilateral procedures. There are parenthetical instructions to be reviewed for these codes as well, so you should make sure to take time, read over those, and highlight them. The vestibule of the mouth is the space between the cheek, lips, and teeth. It is also called the buccal cavity. The frenum or frenulum is folds of mucous membrane in the mouth, attaching the lips to the gum. When cut or excised, it is called a frenectomy. 40819. Now let's look at the incision and excision portion of the tongue and floor of mouth. Just like every other section, it has an incision and drainage. The difference is it is intraoral or extraoral. So inside the mouth or outside the mouth. And then obviously you have that frenotomy code 41010. In the excision section, you have codes for biopsy, excision of lesion, and removal of all or part of the tongue. This is the palate or the uvula of the mouth. A palatoplasty for cleft palate is coded with 42215 through 42225. This is the uvula of the mouth, and this is where the palate is. Now let's talk about some other common procedures on the pharynx, adenoids, and tonsils. A tonsillectomy or adenoidectomy. A tonsillectomy is coded by age and can be primary or secondary. 42825 and 42826. Primary means it is the first time being done, and secondary means it is not the first time being done. Adenoidectomy coded by age and by two different code sets. For primary procedure, 42830 and 42831, and for secondary procedure, 42835 and 42836. Pharinoplasty is when the pharynx is reconstructed. That is 42950. If it is repaired, it should be 42953. Remember, there's a difference in a reconstruction and a repair. Usually a repair is just sutured, and a reconstruction utilizes a graft. A pharyngostomy, we just talked about stomy with the colonoscopies. A pharyngostomy is when they make an artificial opening into the pharynx. 42955. In the esophagus section, you have the incision codes. Esophagotomy, based on approach, was it cervical or thoracic? So you should circle those terms or highlight them. In the excision section, you have the lesion excision based on approach again, cervical, thoracic, or abdominal. And then you have the endoscopy section. This is for the esophagus. We're going to look at my book for these. This is where the esophagoscopy section begins. I have this bracketed by the type of endoscopy used and the approach used. So this one is a rigid. It can these endoscopy procedures are either rigid or flexible, and they are used in different approaches. So this one is transoral, which means through the mouth. A flexible endoscopy is a flexible tube with a light and camera attached to it for your doctor to view. For a rigid endoscopy, is transmitted via video technology, and it's a rod lens system and is positioned in the distal end of the endoscope. So I have bracketed these rigid transoral through the mouth, and as you can see, I bracketed where the transnasal flexible endoscopies started, and I kept going on every page for the transoral, transnasal, flexible, or rigid. I did the same thing for the EGDs, the esophago-gastro-duodenoscopy, which is when the endoscope goes further than it does in the regular endoscopy. It goes past the esophagus to the stomach and to the duodenum. That is why it's called esophago-gastric. Gastro means stomach. Duodeno means duodenum. So this is commonly called an EGD. In the stomach section, you have incision procedures, which include gastrotomies. A gastrotomy is an incision into the stomach. Gastro means stomach, otomy means cutting into. 43500 is gastrotomy with exploration or foreign body removal. 43501 is gastrotomy with suture repair of bleeding ulcer. 43502 is gastrotomy with suture repair of pre-existing esophagogastric laceration, and 43510 is with esophageal dilation and insertion of permanent intraluminal tube. There's also laparoscopy procedures that include bariatric surgery such as gastric bypass. And the abdomen, peritoneum, and OMENTUM section, the common procedure coded here is hernia repairs. They are coded by the type of hernia, inguinal, femoral, or incisional. There's also an umbilical hernia. Some are coded by initial or recurrent. So was it the first time the hernia was repaired, or is it a recurrent repair? And then some of them are coded by reducible, incarcerated, or strangulated. A reducible hernia is one that can be pushed back into the abdomen by putting manual pressure on it. An incarcerated hernia is one which cannot be pushed back into the abdomen by applying manual pressure. An incarcerated hernia can become strangulated, which means it cuts off the blood flow to the tissue that is trapped. A strangulated hernia can be life-threatening if it isn't treated. Some hernias are coded by age. The use of mesh to repair the hernia is not separately reportable except with incisional hernia repairs, 49560 through 49566. Look under bariatric surgery section, laparoscopy. As you can see, there is a code for laparoscopy, surgical gastric restrictive procedure, placement of an adjustable gastric restrictive device. That is a lap band, 43770. If they are doing a revision of the lap band only, it's 43771. Removal of it is 43772. Removal and replacement is 43773. Removal of the gastric restricted device and subcutaneous port components is 43774. Now, if the bariatric surgery was done open, not through a laparoscopy, it would be coded with the codes on this page. Now turn to the anus section and go to excision. Some common procedures here are hemorrhoidectomies. Hemorrhoidectomies are coded based on if it's internal or external excision and how many groups or columns there are. In the diagram on this page, you can see that is a column. It's a group of hemorrhoids. 46221 is the removal of an internal hemorrhoid by a rubber band ligation. 46945 is a removal of an internal hemorrhoid by ligation other than a rubber band. This is for a single column or group. If it was two or more columns or groups, you would code 46946. For a tag of the anus to be excised, it would be coded with 46220 for a single and 46230 for multiple. And 46230 would not be coded more than once per tag. because it has the word multiple and not each. 46320 is for the excision of a thrombosed hemorrhoid that is external. Thrombosed is the key word there. Hemorrhoidectomy external 2 or more columns or groups is 46250. For hemorrhoidectomy external single column or group, there is not a code, so you must use the unlisted code 46999. However, if it is thrombosed, then there is a code which is 46320 that we went over. For internal and external hemorrhoidectomies, I have bracketed that on this page from 46255 to 46262. 46255 is for a single column or group, and 46257 is a single column or group with a fissurectomy, so the excision of a fissure, and 46258 is with a fistulaectomy, including fissurectomy when performed. So that's an excision of a fistula and a fissure. 46260 is 2 or more columns or groups, and then you have the same options with fissurectomy and with fistulaectomy, including fissurectomy. The last thing that we're going to talk about is hernia repair coding that we talked about a little bit earlier, but I wanted to show you how I bracketed my page. For infant inguinal hernias, I have those bracketed from 49491 to 49496. For 6 months to 5 years old for an inguinal hernia, I have it bracketed from 49500 to 49501. For 5 years or older, 49505 to 49507. And for a recurrent inguinal, any age, it's 49520, 49521. I put a note next to the inguinal hernia that says if hernia is recurrent, you see 49520, because you can skip over this because this recurrent one does not go by age. And it's important that you code this even if it's a 4-year-old if it is a recurrent inguinal hernia. Then you have your femoral hernias down here from 49550 to 49557. And then on the next page is your incisional and ventral hernias and your epigastric and umbilical hernias. As you can see, there's one code for reducible, and the indented code underneath it is for incarcerated or strangulated. And that's all for the digestive system. Make sure to study and take your exam.